So is it my time to speak now? I think that's what I heard.
Yes. Yes.
Okay. So good evening. Good evening. Thank you very much. Sorry, I need to go to the first slide. Thank you very much for the kind invitation to your Pan-Hellenic conference. And thank you very much also to Magda Zolaki for inviting me and for giving me the opportunity to present some of my work to you today. Unfortunately, I cannot be in Greece, but I'm happy to present online, and I hope we can have maybe a little discussion afterwards. So the focus of my research is the very early identification of Alzheimer's disease. And I would like to introduce to you the concept of stage 2 of Alzheimer's disease, which is the first symptomatic manifestation before MCI. So these are my conflicts of interest. So this is just a very simplified scheme of Alzheimer's disease evolution. So what you see here is that the pathology of Alzheimer's disease evolves over several decades, as we think today, maybe 30, maybe even 40 decades. And this is what it's here on the x-axis. And cognition stays stable for a very long time. For many years, over 10 to maybe 15, 20 years, the person does not have any symptoms, even though Alzheimer's pathology is evolving. And then there is a slow decline of cognitive functioning. And once it crosses a stage of impairment, we see first very clear symptoms. And this course has been basically divided into 6 stages within the recently published framework of the NIAAA working group by Cliff Jack and al. So as you can see, stage 1 is the pre-symptomatic stage. So this is a stage where the individual has no objective or subjective symptoms. Stage 3 would be what we call nowadays mild cognitive impairment. So we have some impairment, but the person is still normally functioning in everyday life. Then we have stage 4, 5, and 6, which are mild, moderate, and severe dementia stages. But the important stage for this presentation here is stage 2. So stage 2 is called also the transitional stage, the stage where the pathology gets effective and very first symptoms, very subtle symptoms appear, which do not yet fulfill criteria of impairment. So it's very difficult to detect this stage in a patient. But why is this so important? When we look at where we work on the treatment today, for example, antibodies against amyloid, disease-modifying treatment, nowadays starts here at this mild cognitive impairment stage, all the ongoing studies. And the best we can achieve with the drugs ahead is that we slow the disease course, but the person will always stay in the stage of impairment, so it will never revert to normal. So when you look at that graph, it would be even more beneficial for the patient to start earlier, to start here where this very first decline occurs and not wait until the mild cognitive impairment stage. Because if we start here, then we can actually keep the patient for a longer time in a fully unimpaired stage. So the challenge for clinicians is to identify this stage. The good thing is that there is one clinical feature, which is a subjective decline of cognitive functioning. So what people often experience at that stage is that there is something going wrong or something is getting more difficult with cognition. And this is translates to the subjective feeling of declining memory functioning, even though this person still has objectively normal cognition. And I will talk a little bit about subjective cognitive decline as a potential indicator of stage 2 of Alzheimer's disease. So the first study I would like to introduce to you is the German HCODE study. It's a study we did starting from the early 2000s until 2016. In that study, we enrolled over 3,000 participants recruited from the general population. All were 75 years or older, so the average age at baseline was 80 years, and none of them had dementia. And what you can see is that we had very many follow-ups, so we were very much able to model different causes of the disease. So at every visit, we did extended cognitive assessment and other types of assessment, and also asked about subjective decline. So one early study we did here, and what actually also brought myself to the topic of subjective cognitive decline, was an analysis we did quite early in that study, where we had the first 2 follow-ups, so baseline and 3 year of follow-up, every 18 months of follow-up, so every 18 months. So we had to cover, in this study, we covered 3 years. And in this analysis, we only included those 2,400 participants who had fully normal cognition, so not even MCI, fully normal cognition. And in that study, we had 2 questions on subjective cognitive decline. One was the question, do you feel like your memory is getting worse? And if the individual said yes, there was a second question, does that worry you? So these were the 2 questions. And in this analysis, we looked at the risk of getting dementia after 3 years based on these initial subjective cognitive decline questions. This analysis is then corrected for age, gender, baseline cognition, other things, ApoE genotype. And what we saw is that those individuals who say, yes, I have the feeling that my memory is getting worse, they had a 3-fold increased risk of having dementia 3 years later. And those who said, yes, I have a memory problem and that even worries me, they had a risk of 6.5 for later dementia. So this was for us in a way a starting point to look closely at the subjective cognitive decline. So this is a more recent meta-analysis over 11 studies. Looking at SCD as a risk factor for dementia. And on the top, you can see the incidence rates of dementia across all of these cohorts. In cases with SCD, that's the orange bar, and in controls, so people of similar age, cognitively normal, and no subjective cognitive decline. And you can see that particularly in the range between 70 and 90, the incidence rates of dementia in those with SCD are much higher. And on the bottom, you can see that the risk is not only increased for Alzheimer's dementia, but also for other types of dementia. There is a bigger proportion of Alzheimer's dementia, but there is also the green bars and a conversion to other types of dementia. Interestingly, in this analysis, it was found that this effect of risk increase for dementia is much higher in cohorts or samples of people with subjective cognitive decline who come through memory clinics. It's much greater than in comparison to studies from the general population on subjective cognitive decline. So it seems that people who come to the clinic with subjective cognitive decline, but still normal cognition, so not MCI, subjective cognitive decline, normal objective cognition, they seem to be at a particularly high risk for later decline, so higher than those from the general population. So this and other studies has led to a working group, which was started in 2014. And in this work, the aim of this working group was to conceptualize in a way this subjective cognitive decline phenomenon. Until then, there were many different terminologies out there for this condition, but the working group agreed upon this term, subjective cognitive decline, and also provided very broad research criteria. So These are the criteria. So subjective cognitive decline means that an individual has the experience or feels that cognition is getting worse, the cognitive capacity is getting worse in comparison to a previously normal state. And this has to be in a way consistent. So it's not related to an acute event like stress or a disease or something like that. So it's a consistent phenomenon in this individual. This is also the first criterion of mild cognitive impairment, actually. But then on the objective testing level, people with SCD have fully normal age-adjusted cognitive performance. So they are not impaired. That's a difference towards MCI. MCI patients would have also objective impairment. And if this SCD condition is related to some very clear cause, like any specific disease or medication or depression or anything else, then it would be not considered this SCD construct in the context of Alzheimer's disease. So any clear reason for this would also be an exclusion for this SCD in the context of Alzheimer's disease. So there are some more features I would like to talk a little bit about to see what is important about SCD. So one thing are the worries we discussed. So if an individual has a particularly worries associated with SCD, it seems to increase the risk for later dementia. If an individual comes to the memory clinic, this seems to be something of meaning. And in this analysis here, we looked at the consistency of SCD. This is again from the HCODE cohort. Here we had a longer follow-up. And here we used the baseline and the first follow-up visit to define the stability of SCD over time. So this is baseline plus 18 months follow-up. And we, at every time, we ask the individual whether they are subjective cognitive decline. And we define different causes. So on the bottom, you can see in red, we said inconsistent SCD is where somebody only reports SCD at baseline, but not anymore at follow-up 1. So at follow-up 1, this person would say, no, my memory is fine again. I don't have any problems. That would be only at baseline. Consistent would be if the person reports SCD at baseline and also at first follow-up. And consistent with worries would be if at both times point this person reports SCD with worries. And of course, there's a control group who they never report SCD. And what you can see in this graph is that there is a very different risk of getting dementia after 6 years in this case. And the highest risk are those who have consistent SCD with worries at 2 time points, and 1 in 4, so 25% of them have dementia 6 years later. So the consistency of SCD is another important feature for the increased risk of really cognitive decline. And this is another analysis of HCODE where we put into association the first onset of SCD, so the first occurrence or the first report of subjective cognitive decline and objective cognitive performance. So in this study, also from HCODE, we looked at a time frame of 10 years, and we only included in this analysis those close to 1,000 individuals who at baseline had objective normal cognition and did not report SCD. So even though they were 80 on average at baseline, 1/3, so 1,000 participants, when actively asked, said, no, I don't have a memory problem. So it's not that everybody has a memory problem at high age. The majority does, but not everybody. So 1,000, close to 1,000 people here in this analysis did not report subjective cognitive decline at baseline and had normal objective performance. And then we asked them at follow-up, and at one time point, many of them said, yes, now I have subjective cognitive decline. This is what we call incident SCD. So this is this dotted line here, the vertical line. And these color lines are performances on different cognitive tests. And maybe you just look at this at this figure D, which is the most prominent. This is verbal fluency. And what you can see is the green line are those who never report SCD. The blue line are those who report SCD without worries incident, and the red lines are those who report SCD with worries. And what you can see is that when these people report SCD for the first time, they are already actually declining on an objective level, very subtle decline. But this shows that what these people experience and feel is actually real, that the memory is getting worse, but it's still suppressed threshold. So we wouldn't detect it as impaired on a cross-sectional test, but it is still in an individual level already a decline in objective performance as well. So SCD is a correlate of very subtle objective decline. Another important thing here is people often say, well, yes, but when you have dementia, not everybody reports subjective cognitive decline. People just get dementia and they don't experience it in a way, or they don't report it. So we also looked at H-Cody at a 12-year follow-up, and we looked at everybody who developed dementia within 12 years in this cohort of how many of them reported SCD at one time point before dementia, and it was 85%. So 85% of all people who eventually get dementia have a stage where they report subjective cognitive decline. So now I would like to talk a little bit about the correlation or the association of subjective cognitive decline and subtle symptoms with Alzheimer's disease biomarkers to come to this stage 2 of Alzheimer's disease. And I would like to introduce to you a second study. It's a DELCODE study. It's a study which is run by the German Center for Neurodegenerative Diseases, the DZNE. It's an observational study which is conducted at 10 sites in 10 memory clinics in Germany. And it's an observational study where we recruited through memory clinics patients with SCD, so people who come to the memory clinic who report cognitive decline, but who have normal performance on standard cognitive tests. We also included MCI patients, also patients with dementia of Alzheimer's type. And we also enrolled controls who do not have subjective decline through advertisement. And the baseline recruitment is finalized, and we have annual follow-ups, and we do very extended clinical cognitive assessments, MRI, and others biomarkers. I would like to show you a few results of that study. So this is how we defined the groups in detail. So SCD are people, as mentioned, who came to the memory clinic and report memory decline and fulfill these SCD criteria. And normal cognition was defined by normal performance on all tests of the CERAT neuropsychological test battery. It's a very commonly used test battery in Germany because we have good normative data for this battery, even though it's a United States cognitive test battery, but we use it in Germany because of these very good normative data, which are provided by Andreas Monch from University of Basel. And so all these SCD patients have normal cognition, and none of them have like a clinically relevant depression or any other clear diseases which would explain this subjective decline. The controls also have normal cognition, but they do not have a subjective decline of any concern. And MCI and patients with dementia were recruited according to standard criteria, and all participants were older than 60. These are the numbers. So we included 445 SCD cases, 236 controls, 190 MCI, 126 dementia patients. And you can see here the age, distribution of sex and education. And there are some slight differences between these variables, and they are all used as covariates in all further analysis. So this is one first analysis on CSF biomarkers. So we obtained as many CSFs as possible, and we have over 1,000 patients enrolled in total, and we have about 500 baseline CSF. So we were able to obtain about CSF in about 50% of the cases of all groups. Now, this analysis here is from an initial sub-analysis where we looked at the first 400 cases, extracted the first 400 cases of Delcode. This is why the CSF numbers here are lower than in the final analysis, but I can tell you that in the final analysis of the full sample, we found the same results. So these are here the CSF biomarkers, and you can see that we collected CSF biomarkers of all groups, so controls, SCD, MCI, and AD. And what these graphs show is the percentage of patients in each group with abnormal measures in this respective biomarker. So when you look at the ratio, this is the most important here, the ratio of Aβ 42 over Aβ 40, which indicates amyloid pathology, we can see that the yellow bar shows the controls, and we have around about 25% amyloid positive cases in controls, which is what is to be expected at that age range. And then we have close to 40% amyloid positive cases in the SCD group. We have, as expected, around about 60% in the MCI group and 95% in the dementia group. So what we can see here is that we have an enrichment for amyloid positivity in the SCD group in comparison to the control group. And we also observed that on the full data set, and we have amyloid PET in a subgroup, and there we also could confirm that we have around about 38-39% amyloid positive cases in the SCD group, so SCDs from memory clinic. This means on the one hand that 40%, so almost one in two, is amyloid positive of these SCD memory clinic cases. But this also means, on the other hand, that more than 50% of the SCD cases are not amyloid positive, and that is also very important. More than 50% of these SCD cases do not have Alzheimer's disease or amyloid positivity, but 40% have amyloid positivity. So this is a correlation analysis. I just go like this, so it's easier to read. Here we looked at the correlation of CSF biomarkers and cognition. Cognition here is defined by, so we used the full neuropsychological test battery to make factor scores of different cognitive domains: memory, language, executive function, working memory, and visual perceptual function, and a global score. And then on the top, we have the biomarkers. I don't want to go on the top. We looked at the correlation in the healthy control group. So these are the controls, and at the bottom, these are the SCD cases. So both have normal objective cognition, but I don't want to go into single numbers, but the significant correlations are indicated by the blue boxes. And what you can easily see is that in the control group, there's almost no significant correlation between cognition and CSF biomarkers, whereas in the SCD group, there's just about everywhere a correlation between the cognitive measures and the biomarkers. This means that here in the SCD group, the pathology expressed by biomarkers is slowly starting to get relevant with regard to cognitive impairment. So the cognitive function is affected by pathology in the SCD group, expressed by these correlations, where it is not yet affected, where the pathology not yet affect cognitive functioning in the healthy control group. So I would like to switch a little bit back to features, which I also talked about a little bit on the HCODI data, features of SCD that increase the likelihood that people have dementia, that people have Alzheimer's disease pathology, and they are more likely to progress. And these features of SCD are called SCD plus features. And these SCD plus features are subject to change as research progresses, and they are updated based on the research findings. And this is a latest list from 2020 based on the literature at that time. And here SCD features were, SCD plus features were subjective decline in memory. So if an individual reports memory problems and not so much orientation problems or attention problems, memory problems seems to be more indicated, more related to Alzheimer's disease. Rather recent onset within the last 5 years seems to be more associated with Alzheimer's disease. Age older than 60, particular worries or concerns. I mentioned that earlier. Persistent, I mentioned earlier. Seeking medical help, I mentioned earlier. And also confirmation of decline by others. So looking at Delcode, we assessed all of these SCD features and correlated them with amyloid levels. And what you can see here very briefly is that we were able also to, in Delcode, to confirm that there is a particular association of these SCD plus features with amyloid pathology. So we found significant correlations with decline specifically in memory, with the onset within the last 5 years, with worries, confirmation by an informant, and others. So this is just another validation of these SCD plus criteria. Now, when we look at this stage 2 concept, we have 3 symptomatic domains which may occur at a stage 2. One is subjective cognitive decline, which we have discussed. One is very subtle objective decline, which we also have discussed. And the third is very subtle behavioral changes or features that could be mild depression, apathy, anxiety, things like that. So these are also features of stage 2. These are the 3 conditions. Now in Delcode, we looked at all of them and also at the biomarkers as mentioned. And this is here an analysis where we modeled the first 4 stages of Alzheimer's disease based on the cross-sectional data from Delcode. So because we have these 4 groups, controls, SCD, mild cognitive impairment, and dementia, and we have biomarkers in all of them, we can look at, in all of these 4 clinical syndromal conditions, only take those who have amyloid positivity. They would be stage 1 to 4, then in the Alzheimer's continuum definition of the NIA criteria. So these stage 1, 2, 3, and 4 are basically controls, SCD, MCI, and dementia, all amyloid positive in Delcode. And what we depicted here are the different symptomatic domains. So subjective cognitive decline is the red, is the blue one up here. PAC is objective cognition, is the green one here. NPI are the behavioral symptoms, is this one here, I guess. So it's one of these colors. It's difficult for me to see the colors here on my screen. And the others are different biomarkers, including also hippocampal volume. And what you can see here on this graph is very simple, that everything is changing. Symptoms on all 3 domains, so subjective decline, objective performance, behavioral symptoms, and all biomarkers are changing from stage 1, controls, to mild cognitive impairment. That is very clear, but they are also already at stage 2, very different from stage 1. So this is actually where biomarkers and symptoms occur as stage 2 of the disease, and MCI is already progressed. So this is a validation that stage 2 actually contains all these biomarker changes and all these symptomatic features. These are real longitudinal data of Delcode over 5 years. And here we looked at cognitive decline on the PAC, and these are controls compared with SCD. You can see that controls are getting slightly better over time, which is a normal feature of repeated cognitive testing, that healthy people get better and better. SCD patients do not improve, so this is the first sign of declining, is the failure to improve. And when we then separate this by amyloid positivity, so only select those who are amyloid positive, these are the solid lines, we can see that the controls who are amyloid positive are still improving. And the dotted lines are both groups amyloid negative. So the controls amyloid positive are still improving, even though they're amyloid positive, whereas the SCD cases, they are declining over time. Even though they were not MCI at the beginning, only SCD, and they are declining, and this is highly significant. So this again shows that the stage 2 is different also with regard to longitudinal decline than stage 1. In just about all studies around the world, these two stages are one group. And in DELCODE, we have made the separation between controls and SCD. And then when we look further into the biomarkers and we include also phospho-tau, then of course the groups get a little bit smaller, but we can see that within the SCD group, those who are actually amyloid positive and tau positive are those who show the most decline. So within SCD, the subgroup of amyloid positive is one thing, but within that subgroup, the subgroup of also tau positive are those who are actually declining. And that is basically the target group for future treatment, I would think. This is my, I think, final slide. This is a meta-analysis we just published, where we looked at all studies at that time with looking at SCD cases and biomarkers and the risk of getting MCI or dementia at follow-up. And these are the risk indicators. So if SCD has only amyloid positivity, then the risk is about, in an SCD case, close to 6 to get MCI or dementia later on. Tau pathology, the risk is also increased, but not so dramatically. But the most important, if in case with SCD has a full Alzheimer's disease profile, so amyloid positivity and tau positivity, the risk of getting MCI or dementia within a short period of time is over 11. So this is a very high risk indicator. So to summarize, the symptomatic manifestation of Alzheimer's disease starts. I think that's very important. MCI is already a progressed, already quite extended brain damage, irreversible brain damage, which makes it important to think about getting earlier, identifying earlier. One indicator of SCD, one indicator of stage 2 is SCD. However, and this is a very important message for me always, the majority of cases with SCD is not on the track to dementia and Alzheimer's disease, but everybody who gets Alzheimer's dementia in the end will probably, or most people will probably go through the stage of SCD. SCD with AD pathology is often associated with subtle objective decline, not yet easily detectable, but it is there, and sometimes behavioral symptoms. This is exactly the definition of stage 2 of Alzheimer's disease, which can manifest by exactly these symptoms. And this stage, that stage 2 is a specific stage, has been shown by the data that it's a stage where people progress faster than from stage 1. And I personally think that stage 2 is a very good target for future disease-modifying treatment. There are not yet studies in SCD, I must say, but I hope there will be in the future. With regard to the clinical practice, I think we do not yet have enough data to do in our memory clinics to do biomarkers on SCD cases on a routine basis and standard basis, because we don't know yet enough about the predictive power of these biomarkers on an individual level. So we do not biomarkers in SCD on a clinical case. We at present only do it in clinical studies. So thank you very much for your attention. And these are all my co-workers on these studies. Thank you.